started out of out of nothing really. These kids, who've had these diseases for generations, were so often just were lost, in either adult services or inappropriate services, and the damage that they accrued was really terrifying, looking back. And I probably just caught the tail end of that generation. And I've worked through in my career this most incredible integration of basic science and research into the clinical workspace. So we've now got treatments which really work for these kids, not only just in terms of preventing damage, but making them actually feel pretty well on the whole. And I guess we mustn't forget that, really. But equally, we've got a heck of a long way to go. And some of those themes that you've mentioned there, we still have very, very poor understanding of many of these diseases. And I think, sort of generations like yourselves who could, I think, potentially start to have a more integrate genomics with personalizing medical approaches for these patients can only be a good thing. So I work predominantly as an NHS clinician, but I get the opportunity to do a little bit of research and teaching. Like many doctors in the specialty of my generation, I came into this from a very general paediatric background. Eve now is on a specialty training track, as all her paediatric peers are, but integrating research with clinical work. So she'll be hoping to achieve a long-term post that integrates clinical work with research work. So what do I do? Well, we'll come on to a couple of cases just to kind of make things hopefully a bit more real. But as Eve says, we manage youngsters with broadly inflammatory diseases and non-inflammatory conditions, and there's a real range of differential diagnoses. Our ward rounds can take us from intensive care, but can literally cover every ward in the hospital and every sort of specialty in the hospital. If these youngsters have got multi-system disease, they can be under a huge number of different teams. And if any of you are interested in working in specialties like this, obviously you're going to manage kids with chronic diseases. So being able to perhaps engage with families for the long term, think about holistic care, thinking about the impact on whole families and whole people is going to be a really important thing to do. Right. How do I move on? There we go. But I guess, whilst I'm a paediatric rheumatologist by title, I'm first and foremost a doctor. And I guess whatever role we take through our career, we have this fantastic opportunity to work with teams of people, and in order to support our patients. I think I always encourage you to learn from your colleagues. There's a lot of inspirational people out there. I feel I've been dragged along on coattails of some of my very inspiring colleagues over the years. I'd encourage you, now and forever beyond, really, to treat your patients as you would wish to be treated. But also, yes, of course, we should be trying to deliver evidence-based care as much as possible. Whatever area of medicine that you go into, I think there are usually opportunities to develop and at least think about research. It's pretty small scale for me compared to some of my colleagues, but I quite like just that balance, and obviously sort of chance to innovate, and really important that we take our opportunities to teach when we can. So I'm going to run through some cases, folks, to try and bring some of these things to life. But I was going to start just with a little narrative around coronavirus. So I'm sorry if you weren't expecting that, but I wanted just to share some reflections with you around the concept of PIMS-TS, which I'm sure you've all come across in your readings, and probably for those of you who've been around Alder, for each of the waves, you'll have come across lots of talk about this really new condition, new disease. So as you know, kids are really not getting sick with acute COVID, remarkably so. We've really hardly seen any kids admitted with acute COVID. We've also seen, of course, a real drop off in the normal childhood infections that we see this winter, very little bronchiolitis, etc. So very small numbers of children admitted to hospital, 0.9% of all admissions in the first wave. But there's no doubt that there have been some kids with acute COVID who've got very sick, usually youngsters with other risk factors. But as you are, I'm sure, aware that with the sort of the first wave of the virus, about early April, we started to get within our network a real sense of massive concern coming out of London, because the Evelina and Great Ormond Street were literally overwhelmed with patient after patient presenting with a toxic shock illness. So some, the type of numbers that we just never had seen before in pediatrics. So a disease that was looking a little bit like Kawasaki, but not quite Kawasaki disease. And that led to an early NHS England report. RCPCH put together some initial guidelines and initial case definition of this inflammatory syndrome. And we started to get case reports rapidly coming out. The British Paediatric Surveillance Unit mobilised and started reaching out to the paediatric network. We're all members of the BPSU, and we get invited monthly to return if we've seen patients of a particular group that's been studied, and they added this inflammatory syndrome quite quickly to that. Then we started to see some cases being reported in other parts of Europe, and then the USA came on stream a little bit later. And then we started to get more detailed case reports, case series coming out of both Evelina, and then a group published a UK series. Interestingly, there was no cases reported from the initial cohorts in China of children getting sick with this inflammatory syndrome. Just on my the pictures there, just sort of hide this on my screen, but so pediatric inflammatory multi-system syndrome, temporarily associated with coronavirus. SARS-CoV-2 was the European term. Americans, of course, had to be different, so they coined their own definition for it. But essentially, these were a group of kids with evidence of persistent fever, massive levels of inflammation, multi-system disease, in whom there was no alternative cause either, weren't septic. And of course, the vast majority of them had evidence of previous exposure to COVID, and the definitions are broadly the same from the different bodies that coined the definitions. And essentially, this is the pattern that we've seen now in 3 consecutive waves. So the yellow line here, this is data out of the States, shows the rise and the peak of acute COVID within a community, and then 2 to 3 weeks later, the rise of children presenting with a multi-system inflammatory disease. And there's been multiple similar graphs coming out of different parts of the world. So a very significant number of young people getting very sick a few weeks following COVID, but in the numbers, however, are still relatively small in terms of population. Now, what this syndrome essentially looks like is that these are kids, broadly speaking, in the middle part of childhood. So they're often sort of 8, 9 through to early teens. So they're a bit different to the kids who normally present with Kawasaki, or predominantly preschool age children. They have evidence of cardiac dysfunction often, and many need inotropic support. Very common for these kids to present with what looks like appendicitis, so acute abdomen. So 7% of these kids need intensive care, and also need critical care support in terms of ventilation, in terms of cardiac support. A small number of needed ECMO, particularly in the initial London cohort. Massive levels of inflammation based on blood tests, so CRP, ESR, hyperferritinemia. Then we're starting to do tests that we don't normally do, picking up very high levels of D-dimer, high levels of fibrinogen, and very high levels of markers of cardiac damage. The kids are often strikingly lymphopenic, and a number of them become thrombocytopenic. Lots of them have impaired function, both definable on echo or other cardiac investigations. A number of them have have lung disease. So back in probably, where are we now, sort of mid to late April, we saw our first patient. And as you remember, in that initial wave, the cases sort of gradually spread north from London over that first 2 to 3 week period. So this was an early teenage girl who presented actually initially to ED and to the surgeons with what looked like an acute abdomen. But the surgeons weren't quite convinced that this, was truly an acute appendicitis. She had a very striking rash. She got very breathless when she was given some fluid resuscitation because of hypotension. So she had some consolidation and developed some pleural effusions, and we could see some quite striking inflammatory changes on her high-res CT chest. So she got as far as high dependency unit. And there was a very clear history of COVID exposure in this youngster. Her mum was a healthcare worker at Aintree, who'd been COVID positive about 4 weeks ago. Now, at the time, I don't know if you remember, there was a huge amount of anxiety around steroids in patients with acute coronavirus. So whilst we had a very strong sense that this youngster had an inflammatory response, we were actually very nervous and apprehensive about giving a steroid, which you might often do in situations like this. So we networked with some colleagues in London, and we actually gave her an IL-1 interleukin-1 blocker called anakinra, and she got better remarkably quickly. And we were able to publish her case quite quickly. So as time has gone by, I think one of the many successes of COVID, like for example the vaccine, and it has been the mobilization and the accessibility of clinical trials, and making clinical trials work within the clinical workspace. And I'm sure you've all come across the clinical trials on your travels through your placements. But recovery is one of the trials which I think is a true success story. And what the team here, I can only imagine that the chief investigators sat down at the start of the pandemic and drew up a list of what sort of drugs might we need to use to treat patients with an inflammatory syndrome. And essentially what they did is that they made those drugs available, and be available in a way that was going to make clinicians feel confident to use them. So recruiting to these trials is incredibly easy, and it's also the treatment options are incredibly flexible. So it's a recovery trial aims to compare steroids versus no additional treatment, and that's plus or minus use of immunoglobulin. Now, we know that steroids and immunoglobulin are used regularly in Kawasaki disease, which is where I'm sure the rationale for the trial design came from. The trial just gives us lots of discretion, though. If we're anxious or we're not quite sure about how a patient is going, we can revert to what we feel is clinically appropriate for the patient. Now, that might make some of the analysis, when it all comes to the shakeout and the data analysis of studies like this, really quite difficult. But it has meant there's been remarkable uptake and recruitment to studies. And of course, we've seen that with studies in adults. What most of us who've been treating PIMS-TS have found is that most of these patients get better quite quickly with combinations of steroid and immunoglobulin, although we don't know for sure whether they would actually get better without this treatment. So of course there are some patients randomized who receive no treatment. For those who don't get better with first line, there's options to give second randomization to an IL-6 blocker, tocilizumab, and now more recently to the IL-1 blocker, anakinra. So remarkable success story and remarkable integration of research into clinical practice, which I think is something that certainly we've tried to develop in our service over the last decade or so. So, coming back a little bit more to the bread and butter paediatric rheumatology. So here's a typical case that we see very regularly. So a preschool age girl who presents with a 2-month history of morning stiffness and a sense of leg pain. No systemic upset, so not febrile, no rashes, not toxic in any way. And when examined, she's got a warm, swollen knee, right knee here, which is clearly stiff, and you can see there just held in flexion. Entirely normal bloods. Quite rightly, an acute monoarthritis always needs to be sort of considered as sepsis, septic arthritis. Although with a 2-month history and no fever, probably paediatric rheumatologists will be becoming relatively confident to diagnose a case like this without need for a biopsy or fluid aspiration. But certainly if we have any concerns around septic arthritis, clearly important to investigate and to manage as such. And this youngster, as we might expect in JIA, has a very inflammatory looking fluid on cytology. Would be referred through to services like ours, and she has the commonest form of JIA, which is persistent oligoarthritis, and this is a really distinct phenotype. Preschool age girls, extremely common, and what these youngsters are most at risk of is that they carry that by far the highest risk of developing uveitis. So all kids with JIA, as you know, are referred through to ophthalmology for uveitis screening. And they stay on a screening program until they're 11 or longer, of course, if they've developed uveitis. We screen them because they often don't get symptoms, or they certainly don't articulate symptoms. I suspect older children do become aware of symptoms, subtle visual disturbance, etc. But in younger children, certainly those preschool ages, I think it's just very hard for them to articulate what are subtle symptoms. So once we've established the diagnosis, we manage these youngsters very much in the context of a multidisciplinary team. These kids with chronic disease. We're going to give them some non-steroidal just to give some symptom relief, but that's not going to switch the disease off. So single joint intra-articular steroid injection. Younger children will require a GA. And of course, referred over to the ophthalmologists. Very important, of course, then once the inflammation is under control, is then to restore and then maintain function. Now, kids are very good at maintaining function once they're better because they just get up and get going again. But physiotherapy can be very helpful, certainly just in the initial stages. So some of these youngsters, Eve just touched on it, can get a leg length discrepancy. So the disease side, if it's a monoarthritis, so the side of the inflammation will grow quicker. The inflammation the hyperemia will tend to stimulate the growth plates either side of the joint. So uncontrolled, one of the complications of oligo-JIA is that the kids will get a leg length discrepancy, and that will then of course cause a secondary biomechanical problem. So you've touched on that this is a diagnosis of exclusion. Lots of different diseases can cause inflammation of joints, and this is just a mnemonic arthritis that can be quite useful. I'm quite a big fan of the surgical sieve. I apologise to any of those of you who've been in clinic with me and hear me bang on about it, but I think it works quite well for when you consider the range of conditions that can cause joint inflammation. So classification of JIA is based on clinical features. It's a bit complicated. I desperately hope, and again I bang on about this, I'm sure, when I do meet medical students, I'm desperately hoping that one day we'll have a biologic classification, probably based on genomics, and which will give us a much more robust understanding of both disease pathogenesis and how to treat. But we classify according to the onset pattern, systemic JIA, oligo-JIA, and we've seen that youngster there. And a number of these youngsters will present as oligo and stay oligo, we call that persistent, but equally a number will start oligo for 6 months and then subsequently extend. So they'll develop a polyarticular course of disease over time. But that's different to those who start with a polyarticular course, polyarthritis. And then we have two slightly rarer subtypes, so kids with psoriasis and arthritis, or a very strong family history at least of psoriasis, or present with joints that, things like dactylitis, so digits, sausage digits, and then youngsters with enthesitis related arthritis. So this subtype is probably the only subtype of JIA that's commoner in boys, particularly middle-aged boys. So and they almost always carry the HLA-B27 antigen. So second case, in a more typical presentation in a teenager, is a 14-year-old girl who presented with an insidious onset and becoming chronic story of stiffness and pain in multiple small joints, her fingers and in her wrists. As is the way with inflammatory arthritis, much worse in the morning, and if anything better with activity. And that's the balance, the counter of kids with mechanical disease who are generally much worse with activity and better with rest. No fevers, no rashes, clearly functional difficulty with such stiff joints, and you can see that there. If you were sort of getting her to do a PIGALS, just seeing the stiffness and limitation of movements in those small joints. So she's got 16 joints affected, and this, if the polyarticular presentation is within the first 6 months, so this is what we define as polyarticular JIA. So how do we treat that? Well, we want to quickly get this disease into remission. And steroids are very good at quickly controlling inflammation. They're of course not great for long-term treatment control because of the toxicity that builds up. But she's got lots of joints, so this will be a major undertaking to inject 16 joints. It certainly would need a general anaesthetic, and it'd probably take about 2 hours. So we use high doses of pulse IV methylprednisolone. Now, to just give you some context, the dosage that we would use here, it's 30 milligrams per kilo to a maximum of 1 gram of methylpred given IV. But a gram of methylpred is the equivalent of 800 milligrams of prednisolone. So if you think for an asthma attack, you may use 30 or 40 milligrams once a day. 800 milligrams of prednisolone equivalent is a huge dose. So so a massive dose, but very, very effective at a real burst of systemic inflammatory control. And they might give a short tapering course of oral prednisolone. But then to maintain, to get the disease into remission, the steroid, then we've got to maintain it. And that's where longer acting drugs like methotrexate come in. Kids generally tolerate methotrexate much better than adults. And in fact, we can often use higher doses than you would in adults. We much prefer to use subcut rather than oral if we can. It's just that bit better tolerated, and kids generally adapt to subcut injections remarkably well. Folic acid, vitamin to try to counteract any adverse effects. But that's not to say that methotrexate, like any drug, is not without its potential of adverse effects. So a number of these kids do run into trouble with tolerating it. Of course, ophthalmology review before. Not uncommon, unfortunately, though, as in this case, to find that we're not quite under control at 3 months, and actually sort of nausea can become an issue. So we're commissioned to access biologics at 3 months if we're not under control or we're not tolerating. And in the polyarticular form of JIA, it's generally anti-TNF, which is much the most effective. And etanercept is one of the anti-TNF drugs given subcut. Quick burst of methylpred, and usually we'd expect the disease to hit remission at this point. So just to reflect our learning points, poly-JIA onset pattern, and this is more than 5 joints in the first 6 months, can affect small and large joints, can be symmetrical, particularly if rheumatoid factor positive. Those who are rheumatoid factor negative, which is a bit more common actually, can be a bit less symmetrical. We do worry about those with rheumatoid factor positive. It can be a much more aggressive disease, and induce remission with steroids and DMARDs from point of diagnosis. Okay, so moving on, there'll be no secret that this is now sort of moving on to the systemic form of arthritis, systemic JIA. So again, probably slightly commoner in boys and a little bit younger boys. So here's a youngster with some sort of joint symptoms initially, leg pain for 3 weeks, intermittent limp, history of sore throat, and then just starting to get sick, developing fevers, developing a rash, developing more widespread joint pains, admitted to hospital, good going inflammatory response. Not uncommon to find a borderline level of strep titer, so starts on antibiotics, blood cultures, throat swabs, subsequently negative, and despite antibiotics is continuing to spike temperature. He's not getting better like you'd expect in sepsis, inflammatory markers still raised. So not uncommon then for us to get these youngsters referred over or internally referred, and of course starting now to fall into the spectrum of pyrexia of unknown origin. Initially, not much to find with his joints, starting to see a quotidian pattern here. So a temperature that spikes once a day or twice a day. And pretty miserable, sick looking with the temperature, a bit brighter maybe as the temperature settles. But we're starting now to sort of to work him up in terms of wider differential. So usually we want to get a bone marrow in these youngsters, exclude leukemia. We want to exclude infection clearly. Find that he's continuing to be unwell, starting to see signs of this typical salmon pink rash, evanescent. It comes and goes with the fever. More widespread joint pains. Not uncommon to start to see hepatosplenomegaly or serositis, pericardial and pleural effusions. And this is therefore, so now with the exclusion of other causes, we can kind of call this systemic JIA. Short pulses of high dose steroid, again, often very effective at settling the fever, but not probably unlikely for us actually to give 3 days of IV steroid and then discharge him, but there we go. But he comes back 5 days later with now starting to see a bit more arthritis, a bit more steroid, continues to be fever, get him started on methotrexate. Doing okay a few months later, but still getting an intermittent rash and still got arthritis, getting some nausea with his methotrexate. So here's where now we can start reaching for our biologic options. And IL-6 interleukin-6 antibody tocilizumab, much more effective in systemic JIA. So this is IL-6, a much more prominent cytokine than TNF. And generally speaking, these youngsters will respond really well to toci, an intermission and an off-oral steroid. So again, a diagnosis of exclusion, infection, malignancy are two main differentials here, but really important to exclude malignancy before we give these youngsters steroids. If a youngster does have leukemia, of course, steroids will partially damp their leukemia, but may in fact make their longer-term outcome much more challenged. Arthritis may or may not be present initially, but usually develops during the course of the first few weeks. And kids can sometimes grumble along, but more often than not, they're sick enough to need admission and we're sick enough to worry about infection. And the raised strep titers are often a red herring. Okay, right, so deterioration. We've known for decades that a number of youngsters with systemic JA get very sick. And what they do is they develop something called macrophage activation syndrome, and that is described as that because when you take bone marrow from these kids, essentially their macrophages are consuming the cells in the bone marrow. So the more modern term for it is HLH, hemophagocytic syndrome. So beware the child who's with an inflammatory disease, who's not getting better, and particularly when they start doing things like this, dropping ESR, dropping their blood count, their white cell count, the hemoglobin, their platelets, a fall in the fibrinogen. They're essentially, what happens is that their macrophage activating the bone marrow, they develop disseminated intravascular coagulation, which puts their D dimers up. And what happens is they get massively elevated ferritin. So if you ever come across on your travels patients on intensive care units not getting better with antibiotics, looking with ever increasing inflammatory markers, or and this applies to adults as well as children, measure their ferritin, because they're often sort of tens of thousands, hundreds of thousands, and you've got to treat this inflammatory disease before it becomes, but it is potentially fatal. So the journey of a drug to become commissioned, tocilizumab is just quite a nice example of this. Over the last decade and a half, suddenly we've developed an evidence base in rheumatology. So biologic drugs have now become commissioned. For them to become commissioned, they've had to go through very rigorous clinical trials. One of the challenges with rare diseases is getting enough patients. So these trials are usually multi-center. And also, one of the challenges is making trials acceptable to patients. So if you're sick, in the case of systemic JA, sick with those clinical features, it can be quite uncomfortable recruiting to a trial that has a placebo arm. So many of these trials are quite flexible and very reactive to if patients are recruited, if they deteriorate, to unblind or to rescue them if they are on placebo. Not very typical to have an initial placebo-controlled, randomized placebo-controlled phase, which was 12 weeks in the case of tocilizumab, and then those who've responded go on to open label treatment for a much more prolonged period. And tocilizumab in systemic JA was shown to be very effective, and that led to it being commissioned. Once it's commissioned, we can all prescribe it and not worry about hospitals going bankrupt, because NHS England will pick up the tab. Then what we start to do is we start to create standards of care, which we publish and we share. And now in our specialty, what we're very much now desperately trying to develop, and we have the infrastructure coming together for that, is then to start doing some national audit to make sure that patients nationally are all accessing the right treatment at the right time. And then we produce flowcharts like this, which we won't go through, but it just gives us nice sort of pathways of how to treat our patients. Okay, so 2 quick cases, and then we're all done. I'm conscious of that you're not catching your evening just at the moment, but so moving on from JIA, although this patient was initially thought to have JIA, is a not uncommon presentation for us in the outpatient clinic. So a youngster presenting fatigued, very, very stiff, lots of joints stiff, some history of intermittent fevers, but no real pattern, mouth ulcers, hair loss. So on examination, she's got a rather dry feeling inflammation of a joint. So not big boggy effusions, but subtle effusions in these ankle fingers, limited temporomandibular joint, and a malar rash coming across the bridge of her nose, which of course, depending on your skin coloration, can look a bit, can look almost more depigmented if you have a darker skin color. So thought, perhaps not unreasonably, to have poly-JIA, but on investigation, turns out to have a strongly positive antinuclear antibody, but also a strongly positive double-stranded DNA antibody. Lowish hemoglobin, Coombs positive, some evidence of hemolysis, low lymphocyte count, low-ish complement levels, but a rather disproportionate rise in her ESR compared to a CRP. So admitted to hospital, a bit more of a sort of a workup of other systems, what's going on. So a small pericardial effusion, slightly enlarged spleen on abdominal ultrasound, normal chest X-ray, and she has a diagnosis of lupus, and it's this sort of pattern of a high ESR, low CRP, double-stranded DNA, multi-system disease. Of course, is what defines lupus. We don't have a biological test yet, but the American College of Rheumatology criteria, which we need 4 out of the 11, she meets 6 here. So very, very potentially significant disease with impact on multiple organs. Much commoner in girls in our practice. So learning point, positive antinuclear antibodies. There are some studies which have shown up to a third of kids can have an antibody, an ANA positive. So kids going for routine elective surgery have had antibodies checked. So it's only of diagnostic significance if it correlates with a clinical pattern. There's no specific level or strength of the titer which is diagnostic of lupus. It is, however, all present in almost all cases. So to have lupus without a positive ANA would be very unusual. Double-stranded DNA antibodies, however, are much more specific for lupus and seen in around about 3/4 of all cases. Can be a biomarker, so it can be something we can monitor levels of, and we like to see levels falling, provided that the patient is clinically getting better. Complement is consumed by the chronic inflammatory activation and immune complex deposition. So the more active the disease, often the lower it is. And again, with treatment, we often see those levels, the complement levels coming up. Likewise, cytopenia, lymphopenia in particular. And as I say, high ESR and low CRP. So beware the patient with lupus who gets whose CRP goes up. It's almost certainly that they've then got infection. Okay, now Final illustrative example of some of the patients we see kids like this presenting maybe once a year, 1 or 2 every other year, so rare condition. So 7-year-old girl presenting with a 6-week history of pain, thighs, knees and ankles, increasing difficulty walking, lifting her arms overhead, as Eve said, so shoulder girdle, pelvic girdle weakness, symptoms worse at rest, worse in the morning when she gets up, some evidence of inflammation of her joints, some mouth ulcers, family history of psoriasis, thrown in there for just to keep us all thinking. And what she's got is this type of rash. So some malar erythema. If you may just have to sort of to run with me to say that she's got some periorbital edema and some redness around her eyes. And this sort of redness and this slightly pink coloration is described as heliotrope. A heliotrope is a flower seen on alpine meadows, and I've walked a few times in the Alps and always wondered if the pink flowers I see have been heliotropes, but never actually quite worked it out. These youngsters get a rash on their extensor surfaces, so maybe the back of the elbow, the front of the knees, and across the back of the hands, the MCP. These are called Gottron's papules. If you biopsy these, what you actually see is a vasculitis, blood vessel inflammation. So really encourage you, certainly for those of you who go into this sort of specialty, to get familiar with assessing muscles. Both from gait and observation, but doing some more formal muscle strength testing. Classic is the Gowers test, so where youngsters will need to sort of to roll over onto all fours and then climb up, use their hands to climb up their legs to get themselves upright. But very much a proximal weakness. Really beware the youngsters who get both shoulder and pelvic girdle weakness, but who get a lot of core and neck weakness, and they can get actually a bulbar palsy, so swallowing and speech difficulty, because that's a marker of much more severe disease. So how to investigate these? I'm going to open these all up all at once because that's gone slightly out of order. So borderline inflammatory markers, really variable. Some kids get very high inflammatory markers in dermatomyositis, some remarkably low levels of inflammation. Transaminases up, but remember, transaminases can be released from muscle cells as well as the liver. That can make life sometimes a bit complicated if we're treating with methotrexate and the transaminases go up, because we worry whether it's liver toxicity from the drug, but if it could, of course, be coming from the actual disease in the muscles itself. CK and LDH, muscle enzymes, often high, not always. Antibodies, often negative, but ANA can be positive in number. And again, a generation ago, we were very dependent on muscle biopsies in these kids, so an invasive procedure, but MRI has transformed the way we can actually just prove that these kids have myositis. So muscles which on a fat suppressed sequence, which should look dark, just light up bright. So these are muscles of the thigh. So we see this very striking muscle inflammation on the MRI, and it generally means that we don't need to do muscle biopsies anymore. That, of course, means we don't get so much biological tissue, which could give us some material to investigate, but much more appropriate and for the patients not to have open procedures. So maybe as an end point, really important to get familiar with muscle strength testing. There are a variety of ways of measuring muscle strength, to become familiar with the Gowers maneuver, which is a classic sign of proximal weakness. To familiar ourselves with a heliotrope rash, Gottron's papules, I'd say the vasculopathy, so you may see dilated nail fold capillaries, weakness, pain and swelling in the muscles, and untreated or uncontrolled, and again something we'd be very disappointed to see now with the range of modern treatments that are available, but again, tragically a generation or so ago, often youngsters would develop calcinosis in the soft tissues, or calcification. So the blood vessel inflammation in the skin and the soft tissues can lead to calcinosis, and that could be really sort of extremely unpleasant for the patient and very difficult then to treat. So just to come back, bring us back to the word day on the March 18th that Eve was promoting, and just remember that children and young people get rheumatic disease. We're much more familiar with that. I think we're getting much better at treating it. We're getting much better at treating it in collaboration within teams, but also within networks, locally, nationally, and internationally. And I hope that's given you some insight into the world of paediatric rheumatology.
Thanks very much, Dr. Cleary. That's really great.
You're very welcome.
So if anyone's got any questions, feel free to unmute or put in the chat. We'll stay on for a couple of minutes if anybody's got any questions. Joe's put a feedback form in the chat. If everyone could fill that in just to give our speakers some feedback, we really appreciate it. And we can get some certificates out for you as well if you fill that in, if you put your email at the bottom. But yeah, if anyone's got any questions, feel free to put them in the chat and we'll see what we can answer. And thanks to everyone for coming. Dr. Cleary, I was going to ask, do you find rheumatological conditions that run in families?
Yeah, you often, Sean, what I think we often find is we get a subtle association within families. So you might find that there's some diabetes in a generation or two away, or there's some thyroid disease in a generation or two. But these are not dominant conditions. They're not recessive. It's there are genetic factors. And we've got some very strong evidence for that, but they're complex genetic traits. One of the successes of many of the clinical trials now, is that there is the collection of genetic material for biobanking and interrogation of genetic material for investigation, and I'm sure we're going to get answers, much more detailed answers about disease pathogenesis over time, but they're not available for us just yet.
I think we've got a question here.
Fantastic.
What first made you interested in paediatric rheumatology?
Oh gosh, that's a thank you for asking that question. That's
it wasn't me who thought of that question.
Okay, shall I give you a very potted history of a career to date? So next year in 2022 is our 30-year reunion from graduating from Liverpool Medical School. So I was on a Zoom call this time last night, starting to think about how we organise our reunion. So it was like chatting. It was like me back in 1989, honestly, chatting to some of my old classmates. It was fantastic. So I found my way into this specialty completely by chance. And this, folks, it was a very different world back then. So I did finish my F1. We used to call them house jobs, and I thought, right, what am I going to do now? I was vaguely thinking about, as a medical student, I was thinking about doing surgery. I chose surgery as one of my rotations, and I loved the job. And I thought, and I quickly realized I was never going to be a surgeon. But whilst I was doing my surgical job, I did some neurosurgery, and the children's neurosurgery unit was part of that. And I kind of quite enjoyed working around on the paediatric neurosurgical unit. So I applied to Alder for PEDS, didn't get a job. So I was thinking, well, watch that. So I did some adult medicine for a year. And I told my supervisor that I was had this vague niggle in my mind about doing PEDS. So he said, well, okay, well, don't do your next 6 months of medicine. Go and do PEDS. It was at Ormskirk. See what you think. And I did it, and I loved it, and started applying for some paediatric jobs. I then just came across, whilst I was working my way through different paediatric specialties, I just came across rheumatology. I did adult rheumatology as part of that year of medicine, and the two things just started to come together. I enjoyed chronic disease management. I started to become aware of some of the developments happening in the specialty, and some of our beginning understanding of cytokine and cytokine blockers, and I just kind of quite liked mixing chronic disease management with some new potential developments, and I started seeing some patients getting better quickly, and it kind of went from there, really. So a bit of fate, a bit of serendipity, a bit of flexibility, which we had back in the day, in terms of just meandering around doing different jobs. But yeah, and I like working in teams. And I like, I very much like working with, chronic disease management worked for me. Some of the patients do get better. There's a number of these kids actually do effectively get cured and come off their treatment. So that's always, quite a positive experience as well. But of course, sadly, a number of youngsters, the disease does become more chronic. And I just enjoy that, working, the privilege of working with patients in that context. That was a long answer, sorry.
No, it was good. We've actually got a few more questions that have come in. The first one is from Ashley. It says, if a child presents with fever along with pain in the joint, can it be due to any other infections as well?
Yeah, lots of infections. So I guess bacterial septic arthritis, if you've got bacterial infection in multiple joints, you're septicemic and you're going to be really sick. So if this is an ambulant child presenting with pain in lots of joints and fever, it's probably not going to be bacterial arthritis, multifocal arthritis, but always make sure that you think about it. But reactive arthritis, so most viruses can give widespread joint pains, can't they? Vaccinations can give joint pains at times. So the commonest cause of an acute polyarthralgia will be in association with a viral infection. And indeed, of course, that can cause a very transient arthritis. But what differentiates JIA from a transient viral infection is exactly that. If J becomes chronic, 6 weeks or more, of course, your reactive viral infections are much more transient. So if you've got joint pain and particularly joint swelling that's starting to go on for more than a few weeks, it really is unlikely to be a reaction to a virus. But loads of viruses can cause joint pains.
Okay. And then I think we've got just two more quick questions. The first one is from Nicoletta. I'm sorry if I've pronounced your name wrong there. Are there more rheumatic cases now than before COVID times?
Oh, well, so I can't give you any data. I thought you were going to say, are there more rheumatic cases now than a generation or so ago? But I assume not. I assume these are as common now as they were then. I think we're just better at diagnosing them now. We don't know. It will be fascinating, won't it? Will our social distancing, mask wearing, reduction in the number of viruses around the community, will that have an impact on developing autoimmunity? Because of course it's plausible that the trigger for a chronic inflammatory disease, is an initial infection. We don't know that for sure. I would say we are probably about the same in terms of numbers presenting to us through the COVID period of the traditional conditions that we see. I would say there's been a delay in presentation in a number of cases, but for the whole kind of COVID challenges that we've presented with, but we're pretty much back up and running now. But ultimately, it'll be fascinating to see some good, robust epidemiological studies in terms of incidence over these next couple of years, as to whether COVID has either triggered something, it's clearly triggered this acute inflammatory syndrome, or whether we actually see potentially an actual fall in some autoimmune disease because of other measures that we're taking in society. I think that's a watch this space one.
Mm-hmm. Yeah, it'd be interesting to see, won't it, with not just rheumatology, I guess, as well, all other conditions.
Absolutely. Yeah.
So I think we'll maybe make this the last question. It's about rheumatology training pathways in pediatrics.
Okay.
Someone asked, is there now a specific rheumatology training pathway that you'd apply to during your pediatric specialty training?
There is. So have a quick look at the RCPCH website. You'll get a nice clear pathway. But essentially, once you've so the pediatric training scheme, essentially, you do your core pediatric training. It's gonna be at the moment it's divided into 3 phases: SD1 to 3, 4 to 6, and then 6, and then 7 to 8. It's going to change, in fact, to 2 periods of training, but essentially what's called the grid training scheme. So once you've finished your core pediatrics, you would then apply to what are called the national grid training schemes, and then several centres like Alder are registered as centres for grid training. In fact, trainees, because these are quite rare conditions, and the way services are configured can be slightly different across different parts of the country, is that we encourage trainees to actually train in 2 centres if possible, just to get a slightly different sort of experience. But if that's not possible, you can come to to perhaps the bigger centres and use that as your single site of specialty training. But we're badged specialists, but we're first and foremost general paediatricians. And I think probably some of those differentials and the potential scenarios that we come across, we really need that core basic paediatric training first.
Really interesting. So we've got another question came in then, sorry, so we'll try and
thank you.
Sorry about that. So the first one is JIA a long-term condition?
Good question. So we just kind of hinted at it there, didn't I? Sadly, it can be, and it can be for a significant number. Some children do remit and do stay initially on treatment and then stay in remission off treatment, but others clearly don't. And what we really just don't know, we can't distinguish from a biological basis what is it about some disease phenotypes that will run their course, and go into long-term remissions, and whereas others don't. I think if you'd asked me this question at the start of my training, I'd have said, well, yeah, maybe 50 to 60% of cases of JIA will go into long-term remission. It's probably less than that. Now, you've got to be a little bit careful, because the different subtypes will have a different risk of whether they become long-term. So, for example, with systemic JIA, it's a rule of third. A third of kids, it's a really short monophasic illness. Another third, it settles quite quickly, stays in remission, and will hopefully go into long-term remission over a period of time. And another third that are really difficult for the disease to come under control. So a different sort of the different subtypes will carry different risks. And again, I think this is potentially where maybe our genomics will come in and help us to actually quantify that risk and predict that risk. We've just started recruiting to a clinical trial of youngsters with JIA and uveitis who are in remission. And actually, this is a trial of withdrawing their biologic treatment, and we're looking to try to predict some markers of remission, both clinical and some biological markers. So I think, it's again, watch this space.
Okay, and then the final question is: do you know any hospitals that have an internship or any other program of paediatric rheumatology available for paediatricians? Just to add on to that as well, if you want to maybe talk about is there rheumatology SAMP, isn't there as well, project that Alder is available as well, isn't there?
Yes, yeah, we're very keen to have SAMP students, and we've of course had Sean this academic year, but we've got a SAMP available for each rotation. It's going to change, isn't it, next year? There'll just be one SAMP rotation, I think, at the start of the year, won't there? Other internships. So in the UK, it's that grid training program. So once you finished your core paediatric training, you'd apply for the specialty grid. There's 14 sites, 14 centres in the UK that are commissioned to provide paediatric rheumatology care. You'll have to, don't quote me on this, there's about 6 to 8 grid posts at any one time, off the top of my head. I'm not exactly sure nationally. So of course, the numbers of grid posts are mapped and matched to workforce planning, of course, relatively small specialty. Most of the paediatric subspecialties have grid training schemes, follow a similar pattern.
Yeah. No, well, I think that was the last question. Thank you very, very much for that.
You're very welcome.
I thought it was so good. I wish I had that talk before my finals. It would have saved me a lot of time.
Well, you've obviously did all right.
Well, just about, I must have, yeah. But yeah, thank you so much. Such an interesting
problem.
topic, and it's such an interesting area.
Thanks for inviting me.
I'll hand over to Sean quickly.
Yeah, that's great. Same again. Thanks very much, Dr. Cleary and Dr. Smith, for taking up the evening. Thanks very much for everyone that tuned in. Really great turnout tonight. If you've not had a chance, just fill out that feedback form for us, and then that's it. And if anyone wants to ask any questions, feel free to email us. I think all our contact details are on the Facebook event and stuff. So yeah, thanks very much.
Bye bye.